Hello,
Oh,
everyone. We're so excited you're here tonight. Thank you for joining us. We've been doing this for a little while now, and uh, it just gets more fun. That's all I can say. And the content, I hope you guys are noticing, but behind the scenes, we are working really, really hard to fine tune our process and our presentations and the information and the content that we're giving you. Our focus has changed through the years. In the past, we've strictly been education for coding and then coding specialties and stuff. But our education has expanded to where now we've really focused on the clinicians as well as the coders and the billers, the CDI, all of the people on the team that are working in multi-specialties. So I hope that you've noticed a little bit of a change for 2026 because it's intentional. And one of the things I wanted to give you a heads up about, the presentations that we've worked on for you tonight is both for a coder, but for a clinician's perspective. The two topics that we've got for you is coding the mind under stress, accurate documentation of anxiety, trauma, and adjustment disorders. And then from symptoms to specificity, coding mood disorders correctly. This is behavioral health. Behavioral health doesn't always get a lot of love in the coding world. It is a smaller portion of what is out there. However, in the last decade, because of the way the payers have changed and now they pay more for behavioral health treatments, there is everybody scrambling to build their knowledge base on this specialty. And because of that, looking for information and good content can be lacking. And we're going to help you fill this gap this year. We've had a lot of requests for this information. So we're going to talk about documentation that needs to be done for behavioral health and these disorders, what the codes look, what the specificity of those codes are, as well as, when it's time to query. It's really important that as whatever your role is in the industry, that you understand the whole global, not global package like billing global package, but the whole package when it comes to specificity and diagnoses and documentation. So you may see us talk a little bit about from a clinician's perspective, what they need to document, as well as from a coder's perspective. And that being said, wanted to give you a heads up. If any of you are needing specific education like what you're going to see tonight for your organization, maybe your clinics and systems and stuff, reach out to us because we have this content or can build this content for you, and we can talk about how that can be delivered. The best way to do that, though, is to be part of our CCO Club, as well as our academy. And we'll talk about that more at the end. I know if some of you guys are new for us tonight, then you know that we do give you that information. I want to give a special shout out to our interns that worked on these particular presentations tonight. We really appreciate our interns, Lynn, Marge, and Tatiana Walker. They prepared the slide decks and they are fantastic. Again, we've been doing a lot of behind the scenes to find those topics that and fine tune them in a presentation that is appealing and easily deliverable. Thanks for those comments, Catherine. Really appreciate that. Yes. And so let's see. I think, did we want to do any other information before we just jump in, Laureen?
Yeah, you're going to do the first topic and I'm going to do the second. I just had a little choking spell before we started. So thank you, Alicia, for getting us kicked off, and welcome everyone. Well, I can't. I was going to talk to Sandra about how she can't hear anything, but that wouldn't work too well. So I'll type to her while you get started. You're going to pull up the slide deck?
Yeah, let me see. I've got some notes, guys. So I'm going to see how I can make sure I hit all of my talking points with the slide presentation. I don't know how to share that and do that though. So
you need to put it in presenter mode. And then you share the presenter one, but then you use the little.
Okay. I think, let me get to the first slide. I was just, let's see here.
Go ahead, take your time. While you do,
show.
While you get it ready, I'll just go through maybe some of the stuff that we were going to do at the commercial break, and then you let us know when you're ready.
Okay.
So a lot of people are already asking in the, well, one person, sorry, not a lot of people, about the transcript. We do provide a transcript, and we have just the slides, and we have the slides with the transcript. It's actually very well done. We've always done that. That's always been the way I like to have my notes, but it's part of the club membership. We do these presentations for free. We stream them for free, like everywhere that we can that StreamYard allows us to. But the goodies are for our club members, because that's how we support ourselves. The club, you can go learn more about it at cco.us/club. It's $24.99 monthly, or you can do the yearly, which is $249, and save yourself $50 during the year. And there's a few extra bonuses for the annual that you can read about when you go to that page. And here's the pricing, the $24.99 or the $249. We also have a CCO Club Plus, which is everything that you get in the club, plus 2 courses that you can take with us at once. Think of like the coding course and a medical terminology course, or the risk adjustment course and pharmacology or pathophysiology, our new CDI course, and something else. You get the idea. So it's $329 to get into the program, and then it's $99 a month. So if you did our subscription program of $59 a month for 2 courses, you're already saving with that. So that's another consideration if you want both the club and some courses. You all set?
I am. I'm going to share my screen. You guys, if you see me looking around a little bit, I don't know if you guys know all of, but we work multiple monitors. And so that it gets kind of interesting sometimes. All right. I'm going to.
And this slide is talking about our new CDI course, which is going really well. We're just about to put up chapter 3 lecture that Alicia did, and we're getting really good positive reviews. People are really enjoying the new style of lecture that we do, and the beautiful, gorgeous infographic type slides.
It's a lot of fun to do those 2 presentations.
We're kind of regretting that we didn't make it a full course, because it's so meaty, but
it is incredibly meaty.
So the regular price of $724 is what we charge for our ancillary courses. They're supposed to be kind of like half of what our full courses are, but this might actually be as long as a full course.
Yeah.
So
I'm ready to share. Let's see how we do.
Okay.
All right. Right. So this one's pretty exciting, guys. We're going to talk about the coding, the mind under stress. And you know that I love all topics, but this one's a lot of fun. Behavioral health is just one of those areas where documentation is absolutely critical. There's not a lot of knowledge base there, like I said before, and so we're hoping to increase that. We're going to master those F40 through F33 codes, 43 codes with the DSM-5 precision. If you're not familiar what the DSM-5 is, that is the kind of the go-to manual for all behavioral health specialists. And I know this kind of sounds like a mouthful, but trust me, by the end of this, you are going to understand exactly why these codes matter and how they need to be documented properly. Part of our role is to help the clinician with the documentation, as well as, if you're a clinician here tonight, we're going to talk about what needs to be documented. So let's dive in. And this is a little bit of a long presentation, so I may talk a little fast. I hope that doesn't bother everybody, but I want to make sure we get both of these presentations in tonight. All right, let's look at what we're going to go through. First, we're going to distinguish between the different anxiety disorders. There's generalized anxiety, panic disorder, and agoraphobia. And you could be surprised how many times I see documented that the documentation just says anxiety, and that's it. And that's just not going to cut it. We need specificity. The specificity is there in the code set. And we're going to understand trauma and stressor related codes that are acute stress reactions like PTSD and adjustment disorders. Then, and this is really important, we're going to talk about symptom duration requirements between duration, which matters, and it changes your code completely. We'll capture functional impact and severity because you have to have documented how that diagnosis affects the patient's life. We're going to go and look at the DSM-5 diagnostic criteria, and ultimately we want to optimize documentation for coding accuracy and reimbursement. And remember what I always say, we code for statistical purposes. It happens to be a convenient way to get paid. All right, let's look at anxiety disorders first. These are the F40 through F41 codes, and you've got several anxiety codes here. F40.0 is agoraphobia, with or without panic disorder. That has to be documented. There's also F40.01, which is agoraphobia with panic disorder. Then we've got F41.0 is panic disorder, which is also called episodic paroxysmal anxiety. F41.1, generalized anxiety disorder, and we just call that GAD. And then there is F41.2, mixed anxiety and depressed mood, and F41.8, that's other specified anxiety disorder, and that ends up being kind of a catch-all. Now, there's the key distinction you need to remember. Anxiety disorders are characterized by persistent worry. We have fear or panic, and that's not directly caused by trauma. That's key. The onset is typically gradual, and the patient's baseline anxiety is elevated. They're just anxious most of the time is the way they look at it, and will say it, and you'll see that in the HPI a lot. And here's the documentation reality. Many notes just document anxiety without specifying which anxiety disorder. I see this all the time. There's a critical documentation gap there. So we as educators and as specialists in the code set need to relay that to the clinicians. We need to know, is it panic? Is it GAD? Is it agoraphobia? Each one has different criteria and different codes. And, again, educating our clinician is going to be really important in all of that. Let's start with the panic disorder. That's going to be F41.0. And I want to walk you through what the DSM-5 diagnostic criteria is, because this is where your clinician needs to be documenting specifics. First, you have to have recurrent, unexpected panic attacks, sudden surges of intense fear, for example. The patient has to have at least 4 symptoms: racing heart, sweating, trembling, shortness of breath, chest pain, nausea, dizziness, derealization. And that is like when they just have that feeling that things aren't real around them. Fear of losing control, fear of dying, numbness, chills, and heat sensations. Those are all symptoms that they can have, and you need at least 4 of those. If they only have, say, 3 documented, then you would probably query on an initial diagnosis. Then they have to have persistent concern about future attacks lasting at least a month. So it's not just that they had one attack, they're worried it's going to happen again, and that worry lasts for at least a month. And then you have to have significant behavioral changes related to the attacks. And again, a lot of times this is all going to be information that's going to be able to click off in the HPI. So what do we need to see documented? So for our clinicians, we need the frequency and the pattern. That's key. How many panic attacks per week? Are they expected or unexpected? What specific symptoms did they experience during the attacks? How long did the symptoms last during the attack? Usually it's about 5 to 20 minutes is what you'll see. We need that timeline. Then did the panic attacks start at a specific time? How long have they been going on? What behavioral changes happened? Are they avoiding situations? Are they seeking safety behaviors? And what's the functional impact? They can go, are they able to go to work? Are they able to have a relationships? Is that being affected? And can they do activities that they are normally used to doing, or is it preventing them to do that? Now, common documentation errors is that, and I see these a lot, panic attack without any documentation of the signs and symptoms. You've got to have those 4 symptoms documented: anxiety without specificity, that these are panic attacks, and missing the duration of that is concerning. And remember, it's got to be at least 1 month. If specificity is not there, then you can't code it. You'd want to query, and there's a proper way to query. Moving on to generalized anxiety disorder, that's going to be your F41.1. Now, let me give you some perspective on how common this is. 20% of people across the globe suffer from anxiety disorders, and that's 1 in 5 in the US alone. So that's 6.8 million adults which are affected by GAD. About 5.7% of adults will experience GAD at least once in their lifetime, and women are more likely to suffer from GAD than men. And here's something really important: 66% of people with GAD also suffer from some type of depression. Now, the big thing to remember here is duration: 6 months. The patient has to have excessive worry about multiple areas of life for 6 months or longer. If it's been 5 months, then it's probably not going to be GAD, and a query might be involved. You might document it is early GAD or GAD or other anxiety disorder, but you can't use F41.1 until you hit that 6-month mark. Again, time to query if that's in question and not documented. That doesn't, by the way, have to be documented with every single encounter if the diagnosis is established. So don't think that you can't code it without asking, or it already being in an existing condition. They also have to have difficulty controlling worry, and it's just that, not that they are worried, that they can't turn it off. They can't manage that, and they need at least 3 of these symptoms to meet that criteria: restlessness, easily fatigued, difficulty concentrating, irritability, muscle tension, or sleep disturbances. A lot of times they'll sleep too long, or they can't sleep at all. Again, you need to have 3 of those documented for that initial diagnosis. And don't just say anxiety symptoms. You want to be specific, and there has to be significant functional impairment that needs to be documented. So what do we actually want to see documented? What is the patient worrying about? Health, finances, family, work, all the above. It can be anything, but we need to see something documented there. How long has the worry been present? Again, 6 months is that minimum for this diagnosis. Which physical symptoms are present? You've got to specify at least 3. And then what's the functional impact? How does this worry affect their work, their relationships, their daily functioning in life? Is the patient anxious most days? What's baseline? And can they control or manage the worry? Usually the answer would be no, but we need to see that documented. And here's an example of really good documentation. Patient reports persistent excessive worry about health, finances, and family safety for the past 8 months. Reports difficulty concentrating at work. muscle tension, and poor sleep 4 to 5 nights per week. Denies being able to control worry, reports significant impact on work productivity and relationships. That's excellent. That's beautiful documentation. And it tells me everything I need to know to be able to translate properly. So compare that to just writing generalized anxiety disorder or just GAD with no details, right? Not going to be as helpful. Okay, agoraphobia. That's going to be F40.0, and it's often overlooked. Here's the documentation reality. Agoraphobia is frequently underdocumented. Clinicians will write, unable to leave home without actually coding or documenting agoraphobia. And that's a missed opportunity because this is actually a specific diagnosis with that specific criteria. You may or may not know that a lot, especially in behavioral health, a lot of clinicians have to code themselves, and they just wait for an external audit or an audit, or they never have an audit. So again, it's really important to make sure we have the proper description as well as the proper code picked. Let's look at and see what the DSM-5 diagnostic criteria is going to be on this one. The patient has anxiety about or avoidance of a specific situation. It could be public transportation, open spaces, enclosed spaces, crowds, or being outside the home alone. They're afraid that escape would be difficult or that help wouldn't be available if they needed it. Now, the anxiety is out of proportion to the actual danger. I mean, they're not in a war zone, but they're reacting like they are. The avoidance of significant and distress, they get really distressed over what normally would not seem like a stressful situation, and it actually can cause functional impairment. So what do we need to see documented for this diagnosis? What situation caused the anxiety? And they need to be very specific. Public transportation. Is it crowds? Is it open spaces? And what's the patient actually afraid of, and what will happen in that situation? Are they afraid they'll have a panic attack? Are they afraid of embarrassment? What exactly are they worried about? And how much avoidance is happening? Do they never leave the home? Will they only leave with a companion? What's the functional impact? Can they work? Can they participate socially? Are they independent, or say, are they relying on others to be able to leave the house? And here's a big one. Does the patient have panic disorders too? Because if they do, you code the F40.01, which is agoraphobia with panic disorder. That shows specificity. Now, here's an example. Patient reports intense fear of crowds and public transportation, avoids shopping, public venues, driving on highways, leaves home only with spouse, unable to attend work meetings or social events, fear related to concern that others are watching and judging. That's 40.0, agoraphobia with documented functional impact. All right, now we're moving into trauma and stressor related disorders. These are F43 codes. And this is where things get really interesting because we have to pay attention to timelines with these codes. Okay, here are the major codes. We have F43.0, which is acute stress reaction. That's 3 days to 4 weeks post-trauma. Then you have F3.1, which is PTSD or post-traumatic disorder, stress disorder. And that's more than 1 month post-trauma. We've got F43.10, which is PTSD unspecified. F43.11 is PTSD chronic. And then F43.12, which is PTSD acute. Then we've got F43.2, which is adjustment disorders. Okay, so within 6 months after a stressor, that's going to be applicable. Here are the subtypes. We have F43.21, which is depressed mood, F43.22, which is with anxiety, and F43.23, it's with mixed anxiety, depressed mood. And then wrapping up, we have F43.24, and that's disturbance of conduct. Now, here's the key distinctions that you need to be aware of. All of these require an identifiable stressor, either trauma or a life change, and they differ in severity, duration, and symptom pattern. You've got to pay attention to those timelines because the timeline tells which code to use. Okay, let's talk about acute stress reaction. This is F43.0 and it's limited. Here's what you need to know. The patient has to have exposure to an actual or threatened death, serious injury, or sexual violence. That's your trauma. Symptoms are present from 3 days to 4 weeks after the trauma. If it's less than 3 days, you just document it as a stress reaction. If it's more than 4 weeks, you need to reassess for PTSD. Now, symptoms include intrusions, that's flashbacks and nightmares, negative mood dissociation, avoidance, and changes in arousal. And there has to be a significant distress or functional impairment. I have a friend of my mother's who actually had gotten shot as by a strange, it was just a strange situation, wrong place, wrong time. She has PTSD and can't go out in public easily by herself. And so that would be an example. Here's your critical timeline: 3 days to 4 weeks post-trauma equals F43.0. More than 4 weeks post-trauma, then you would reassess. You're probably looking at PTSD at that point. Now, what do we want to see documented? What was the specific traumatic event? Example, the person was, a shooting. We need the date, the type, the severity. When did symptoms start? Did they start immediately, or was there a delayed onset? Which specific symptoms are present? Do they have flashbacks, nightmares, avoidance, hypervigilance, disassociation? And how long did have the symptoms actually been present? Now, this is critical because days versus weeks determines whether it's F43.0 or PTSD. And that also means you need to know what the functional impact is. Can they go to work? Can they sleep? How are their relationships? And is the patient in danger or at risk? You've got to, do a safety assessment. Now, here's an example, again, of really good documentation. Patient exposed to motor vehicle accident 10 days ago as a passenger. Multiple injuries to other occupants, reports intrusive recollections, avoidance of driving, hypervigilant, sleep disturbance. No disassociation noted, functional impact, unable to work, anxiety in cars. That's F43.0, acute stress reaction. Okay, now we're getting into PTSD. That is F43.1, and there are 4 symptom clusters. You've got to have all of them documented. First, trauma exposure, actual or threatened death, serious injury or sexual violence. Then you've got that cluster B, which is intrusion, recurrent intrusive memories, nightmares, flashbacks, distress at reminders, and psychological reactivity. Cluster C is avoidance. The patient is avoiding trauma-related thoughts, feelings, conversations, people, places, activities. Now, cluster D is negative cognition and mood, then persistent negative beliefs or expectations, persistent negative trauma-related emotions like guilt, shame, anger, fear, diminished interest in activities that they usually enjoyed, feeling detachment from others. Then there's constricted affect. And cluster E is arousal. You have hypervigilance, exaggerated startle, and reckless behavior, irritability, concentration difficulty, sleep disturbances. And with sleep disturbances, remember that can be too much sleep or not enough sleep where they get insomnia. The duration is got to be more than 1 month. And if it's more than 3 months, that's F3.11, which is considered chronic. Now, if it's less than 3 months, that's F43.12, acute. And there has to be a functional impairment. So significant stress or functional impairment being documented, whatever it might be. Now, here's the common documentation gaps. PTSD without documenting specific symptoms for each cluster or missing trauma details. It just says trauma without describing what it is. No functional impact documented and not distinguishing between acute and chronic. You need that timeline. So if it's not there, again, these are query opportunities. So what we need to document for PTSD, what's the trauma? What's the date, the types, the severity, the mechanism of exposure, which cluster, B symptoms, at least one's going to be required, and you need to be specific. Which cluster C symptoms, and which reminder are triggering avoidance. Which cluster D symptoms? Does the patient have negative beliefs about themselves, emotional numbing, guilt or shame about what? And then with cluster E symptoms, hypervigilance about what? Sleep problems, how often, how long since the trauma. Then you've got that critical for chronic versus acute coding that needs to be documented. What's the functional impact? Is it work, relationships, self-care, safety? And are there any dissociative symptoms? There's a dissociative subtype you can code if that's present. So you want to be aware of that. Now, here's an example with really strong documentation. Patient exposed to combat in Afghanistan 18 months ago reports persistent, intrusive memories and nightmares 3 to 4 times per week about a firefight in which unit members were killed, avoids loud noises, crowds, news about the military. Reports persistent guilt about surviving when others didn't, and believes that he is broken and damaged. Hypervigilant, startles easily, irritable with family, sleep severely disrupted, withdrawing from friends, reduced work productivity, reports flashbacks during PTSD triggers, denies disassociation. And now that is F43.11, PTSD chronic. And that's beautiful documentation for that. And you can code that all day long. Okay, now we're going to look at adjustment disorders. This is going to be F43.2, and it's different from PTSD because it's a response to non-traumatic stressors. So what's a non-traumatic stressor? We're talking about job loss, divorce, illness, maybe a financial crisis, death of a loved one, relocation, retirement, maybe. These are all stressful situations, but they're not the same as trauma that meets the PTSD requirement. The emotional or behavioral symptoms, they're going to develop within 3 months of the stressor. So something happens, and within 3 months, they're having these symptoms. The symptoms exceed a normal response and cause significant distress or functional impairment. And here's the key: duration. Symptoms resolve within 6 months after the stressor ends or within 6 months of the diagnosis. So it's time limited, and it's not better explained by another disorder. So again, you'll see that comparison, like differential diagnosis, used. There are different types. F43.21 is with depressed mood. That would be like sadness, feelings of hopelessness. F43.22 is with anxiety. That's nervousness, worry, the jitters maybe. F43.23 is with mixed anxiety and depressed mood. You have F43.24, which is with disturbance of conduct, rule breaking, irresponsibility maybe. F43.25 is with mixed disturbance of emotion and conduct. And then you have F43.29, which is with other symptoms. Now, how do you distinguish it from PTSD? If the same patient had flashbacks to the moment of, say, termination, hypervigilance in social setting, and guilt about not being good enough, avoidance of seeing former colleagues, that would suggest PTSD if it was a traumatic termination or more complex presentation. So you've got to reassess the situation. So, what do we do when we see documentation for adjustment disorders? What's the specific stressor? Is it job loss, divorce? Is it a medical diagnosis or death? And when did the stressor occur? Now, the timeline is going to be critical because that 6-month window, what emotional or behavioral symptoms develop, specify which type applies. Is it depressed, anxious, conduct? When did symptoms start? Should it be within 3 months after the stressor? And what's the functional impact? Was it work, relationships? Maybe it's self care. And has the patient experienced previous adjustment difficulties with similar stressors? That really gives conduct or context. Now, here's the critical distinction from PTSD. Adjustment disorders is a response to non-traumatic stressor, and the symptoms are proportional to the stressor severity. So PTSD is a response to trauma, and the symptoms often exceed the stressor severity. Plus, PTSD has specific symptom clusters that you have to document. Now, here's an example. Patient lost job 2 months ago after company downsizing. Reports depressed mood, difficulty sleeping, decreased appetite, loss of interest in hobbies, worrying about finances, unable to concentrate on job search, feels hopeless about future employment, relationships with family are strained, prior history of resilience with previous job changes. That's F43.21, adjustment disorder with mood, depressed or depressed mood. Okay, let's talk now about duration and the onset, because this is absolutely critical for coding. So symptoms, duration matters. Let me show you with this chart. If you look at it, you're going to see panic disorder. You need concern about attacks for more than 1 month. That's F41.0. Generalized anxiety disorder, worry for 6 months or longer. That's F41.1. Acute stress reaction, 3 days to 4, post, that's 3 to 4 weeks post trauma. And there's F43.0, PTSD acute, more than 1 month, but less than 3 months post trauma. And that's F43.12. Then PTSD chronic, more than 3 months post trauma. That's F43.11. Adjustment disorder is within 3 months of the stressor and resolves within 6 months. That's the F43.2. And then, of course, you'll have that last character. So what are the documentation requirements that we want to see? When did symptoms first appear? Specific date or time frame? How long have the symptoms been present? We've got days, weeks, months, years that need to be documented. Are symptoms continuous or episodic? When did the identifiable stressor or trauma occur? And you need the timeline relative to the symptoms. And are symptoms improving? Are they stable? Or are they getting worse? Now, here's an example of really good timeline documentation. Panic attacks between 8 weeks ago without a clear trigger, now experiencing 2 to 3 attacks per week. Persistent worry about future attacks, avoids driving due to fear of an attack in the car. Symptoms stable over the past 2 weeks, not improving with therapy alone. And now that tells me everything I need to get a proper code. All right, let's talk about functional impact. This is so important, and I cannot stress this enough, guys. Why does functional impact matter? It's required for the diagnosis. It's in the DSM-5 criteria. It demonstrates medical necessity. It justifies the level of care and intensity of treatment, and it impacts risk adjustment and reimbursement, which is really important. So, what are the key function areas we need to document? Number 1, work or academics. attendance, performance. Can they concentrate? Are they having absenteeism? Have they lost their job? Okay, here's an example. Unable to return to work, took 4-week medical leave due to anxiety, or productivity decreased 50% due to difficulty concentrating. That's functional impact. Now, number 2, relationships, family conflict, social withdrawal, isolation. Can they maintain relationships? Example, for us is avoiding all social activities, withdrawn from family, or increased marital conflict. Spouse reports patient is withdrawn and irritable. Okay, number 3, let's see, self-care. We have hygiene, nutrition, sleep, substance use. An example could be neglecting personal hygiene, sleeps severely disrupted 2 to 3 hours per night, or using alcohol to manage anxiety, consumption increased from 2 to 8 drinks per night. That's going to be a red flag right there. Number 4, safety, suicide or homicidal ideations, self-harm, reckless behavior. Now, an example would be passive suicidal ideations, engaging in reckless driving during panic attacks, or denies current safety concerns but reports urges to self-harm when triggered. You've got to document all of these in like a safety assessment. And number 5, daily living. Can they perform activities of daily living? Are they making medical appointments? Can they advocate for themselves? Another example, would be unable to leave home, spouse managing all appointments and errands, or difficulty managing medical appointments, missed diabetes follow-up due to anxiety. Here's a full documentation example. GAD or GAD significantly impairs functioning, unable to work full-time, took medical leave 2 months ago, avoided family gatherings for 4 months, sleep disrupted 5 to 6 nights per week, difficulty concentrating on basic tasks, relationships strained with spouse due to worry-related irritability. That's all really comprehensive. That's what we need to see. All right. Let's look at real world examples. We're getting ready to kind of wrap up. I love doing these because this is, where it all comes together. We got the first example. Panic disorder, F41.0. Here's the documentation. Patient reports sudden episodes of intense fear with heart racing, shortness of breath, trembling, and feeling like he's dying. Attacks occur 2 to 3 times per week without warning, lasting 10 to 15 minutes. Reports worry about having attacks and avoiding driving. Started 3 months ago after a car accident where he witnessed a minor collision. Attends university. Grades declining due to anxiety about panic in lecture halls. That's an F41.0 panic disorder. Now, the documentation quality is really strong here, and it includes the symptom specifics, frequencies, a trigger link to the accident, and functional impairment. That's everything you need. Now, here's another example. PTSD, chronic, F43.11. 33-year-old presents with PTSD related to home invasion robbery 14 months ago. Reports recurrent nightmares 4 to 5 times per week of the perpetrator. Flashbacks triggered by sounds, darkness, or unfamiliar faces. Avoids leaving home except for therapy. Avoided friends, homes, and public spaces. Reports persistent guilt. I should have done more to protect my family. Hypervigilant, exaggerated startle response. Sleep is fragmented. Significant relationship impact. Wife reports patient is emotionally withdrawn and irritable with children. Unable to return to work. Previously a field sales representative. That's an F43.11 PTSD chronic. Now, documentation quality is strong here. You've got trauma details, multiple symptoms, clusters documented, intrusion, avoidance, negative cognition, arousal, timeline documented, and functional impairment. So it's perfect. All right, Now, let's talk about common documentation gaps, because this is where the CDI, or the clinical documentation improvement, really comes to play. And this is why we're launching our CDI course, by the way. So this is really important. Now, here is the frequency of gaps that I see all the time. Number one, non-specific coding of anxiety without specifying panic versus GAD or GAD versus agoraphobia. Number two, missing duration, no documentation of symptoms onsets or how long symptoms have been present. Number three, insufficient functional impact. Notes document symptoms, but not the impact on work, relationships, or self-care. And then number four, no trauma details. PTSD without describing the traumatic event or mechanism of the exposure. And number five, you got unclear stressors. You've got adjustment disorder without documenting the specific stressor. Number six, missing symptom specificity. Is there anxiety without documenting which symptoms, like physical, cognitive, behavioral? Number seven, no severity assessment. Symptoms count not documented, critical for PTSD cluster diagnoses, as an example. And number eight, under-addressed comorbidities, anxiety plus depression, but only one is coded. So what are CDI intervention examples? Now, here's one of a query you can use. Does the patient meet criteria for generalized anxiety disorders, 6 months or more of worry about multiple areas versus other anxiety disorder? Please clarify. Panic attacks occurring occurring 2 or more times per week for how long? Has the patient had concerns about future attacks for at least 1 month? Please document specific functional impact of anxiety on work, relationships, sleep, and self-care. And then for PTSD diagnoses, please document nature of traumatic event, trauma-related intrusive symptoms, avoidance symptoms, negative trauma-related cognition or mood, and list them like, A, B, C, D, and that's how you improve documentation. All right, we're going to wrap up. Let's look at the 5 critical takeaways we have for this. And number 1, specificity saves. Distinguish anxiety types, panic versus GAD or GAD versus agoraphobia, with specific diagnostic criteria documentation. Don't just have anxiety. Number 2, timeline is essential. Document symptoms, onset duration, and it's critical for coding distinctions. You have F4 3.0 versus F 3.1, acute versus chronic PTSD, because the timeline really matters there. Number 3, functional impact demonstrates medical necessity. Always document how anxiety or trauma affects work, relationships, self-care, and safety. And that's what justifies the treatment. That's what gets you reimbursed. So number 4, cluster documentations for PTSD. Document symptoms from each DSM-5 cluster. Is there intrudence, avoidance, negative cognitions, arousal? And that count really matters. So you've got all 4 clusters that you need to be aware of. And number 5, stressor identified matters. The identifications for adjustment disorder clearly identify the non-traumatic stressor. For PTSD, clearly identify the traumatic event. Now, implementation action items. What are you going to do with this information? Train your clinicians on F40 through F43 diagnostic criteria and documentation requirements. Implement structured templates that prompt for symptoms, onset, duration, functional impact, and stressors or trauma details. You can establish a behavioral health CDI program with queries focused on things like specificity, duration, and functional impact. You can link anxiety and trauma documentation accuracy to quality metrics. You can create a quick reference guide for diagnostic criteria and documentation tips, or for clinical staff, and educate your coders on the DSM-5 criteria changes and any coding implications that happen every year when codes change. Now, the resources, again, we've got those here for you. You've got the DSM-5 TR, and that's the updated diagnostic criteria. Of course, we got ICD-10 where you can look at the F40 or 40 through 43, and the coding manual, which has the clinical definitions in them. AHIMA's clinical documentation improvement toolkit, that'll specifically give you behavioral health sections that you can rely on. There's a VA PTSD National Center resource on PTSD diagnoses. And I'm showing that my battery is running low. So I am going to have to, let's see, let you read the rest of those. Okay, guys, we did it. We got through all of them, and it's time to pass on to Laureen while I find my cord.
All right, great. Yeah, that was fantastic. I know that was a lot, a meaty 18 slides, but again, you can get access to these slides if you're a CCO Club member. And if you're not, you can rewatch the video because it's streamed. It's wherever you were watching it, like on YouTube and places like that. So definitely go find it there. So let me finish the rest of our commercial break, because this is where we normally do it. Last time, I think it was the last time, recently, we did a presentation on forensic coding as becoming like a forensic coding specialist. There is not a certification for it, but so many people reached out to us or through social media and said, I want to learn more. I'd like to do that. So we're setting up an interest list. I'm going to send this out to everybody. Oops, I think I just sent it to one place. Let me send it everywhere. So yeah, if you want to get on the early interest list, this is where, like with the CDI course, we normally offer it at 50% off. It's the absolute lowest that we'll ever offer it. It's not going to be coming like immediately. It's probably going to be beginning of next year, quite honestly, because we're finishing up the CDI course. We've got some other courses we're going to do in between, like just kind of refreshing some of our existing courses. So, but yeah, if you're interested in that, we're going to start at least fleshing out the outline and writing a textbook. And so it's kind of exciting. So then the pricing table, we normally like to go over that. It's the difference between, it's something we introduced in, Alicia, I'm so sorry. Could you take over these slides?
Yep.
Because I have someone at my door I have to answer. I'll be right back. I'm so sorry, guys.
Yeah, let me just change my view here, guys. Sorry. So the pricing table, like she said, we've been making some improvements, and the great thing about the price is that lifetime $59, and the comparison here really spells it out. But brilliantly, you can mix and match your different specialty interests by using that lifetime. Now, of course, the 9-month is also brilliant, but for a low price of $59, sounding like a commercial, look what's available for you. Go ahead.
Yeah,
You can
it's
jump back in,
actually,
Lori.
it's not 9 months anymore. We've changed it. So now you have a choice, rent or own. 59, subscription,
How I
or
like to say it.
purchase it outright, and then you have access forever. So when we do, like we just talked about refreshing some of our courses, you'll get access to all those updates, the updated slides, all that good stuff. And you always have access to us. So thanks, Alicia. Appreciate that. This is just letting you know how to get to our YouTube channel. If you don't know, we have videos going way back. So now we're going into our archives and we're refreshing them, and we're going to be bringing them forward with updated information and fresher look. So all you have to do is put @CCO at the end of youtube.com and you'll find us. And a tip, when you're on YouTube in your desktop mode, it doesn't work on mobile, but there's a little magnifying glass, and you can type in a keyword like diabetes or CDI or what, and you'll get all of the videos on that topic that we've done. You can use it for other channels for other interests that you have. Upcoming events, Thursdays are CCO nights. So tonight we're doing the club webinar. That means this one is approved for CEUs. And I gotta vent, guys. AAPC increased the price of their CEUs from $330 to $413 or something like that. I'm just like, so, it's annoying. It's annoying. So please tell your friends to become club members so we can spread that cost out and be able to get more approved for CEUs. But anyway, it's frustrating. So this is the lineup. All you have to do is go to the Academy, cco.academy, click on events. You'll see everything that's coming up. It's so easy. Just click on it, register, and you'll get the reminders. We have an affiliate program. If you're interested, I'm going to put the oops, where did it go? It's just go to cco.us, Laureen-call, get on my call schedule, and we can talk about it. We don't let everybody do it. We want people that kind of have a following, but we are going to be bringing a referral program, which is different. It's like you telling one-to-one a friend about CCO and maybe being able to earn some money or earn some, courses or blitzes and practice exams, that kind of stuff. And the platform, we launched it in July. It still feels, fresh and wonderful to us. It's got mobile. Check it out, cco.academy. You do not have to be a student or a club member to enjoy it. We have a very nice free community area. So it's really worth checking out. And if you do become a premium member, which is a student or a club member, you get access to our Cody bot. And Cody bot is really doing phenomenal. It's trained on our entire library of courses, every webinar we've done, like topics like this. And you ask Cody bot a question on major depression, it'll pull it up. And you can go back and forth. So, well, can you clarify this point a little bit? And for our students, we tell them just before you take your end of chapter exam, ask Cody to ask you a multiple choice review question, but don't give me the answer. And he will. You give it the answer, and he'll come back and tell you if you're right or wrong and give you the rationale. And then you say, thank you. May I have another, please? And then you can do as many as you need till you feel satisfied, and then go take the test. So it's really awesome. And if you need a consultation, I did one today, career advice. They wanted to do a particular course. And I said, well, it's very similar to what you already have. Why don't you try this? And they're like, you're wonderful. You're awesome. So, just a little bit of guidance can really help. And if you heard me, I was not saying, oh yeah, buy the full course and get 3 of them. I was like, no, you could probably just do 1 month of 59, get a refresher on this, then go do the time practice exam. So I'm not about trying to oversell you. I'm about helping you get exactly what you need for the goals that you have. So connect with me. I can do evenings and Saturday mornings. And then topic requests. Someone mentioned, I'm so happy that you guys are doing this on mental health. And it's because you guys asked us to. So we develop it and then we present it. So you drive these webinars. So keep those topics coming in. We really appreciate that. All right, so let me switch to my presentation. And
I am going to take myself off the screen.
Okay. Thanks, Alicia. And you can, monitor the chat. So this one is from symptoms to specificity, coding mood disorders correctly. Oops, let me go back here a little bit. So what we're going to cover here is the F codes, but by the time we're done, you're going to feel a lot more confident with these. And it's just one of those areas where the being very specific really, really matters, not just for reimbursement, but for compliance, for medical necessity, really all of it. So we're going to break it down together step by step, but don't forget, you can always put your questions in the chat and, we can interact with them after. Okay. So what are we hoping to accomplish with this presentation? By the end of this, you're going to be able to differentiate between major depressive disorder, which is dysthymia, just think of your thigh to pronounce that right, which some of you might know as persistent depressive disorder, and adjustment disorder. These 3 get mixed up all the time. So we're going to talk about what documentation elements you absolutely need to code these correctly. because, we can only code what's documented, right? That's our golden rule. Then we're going to talk a little bit about HCC 59, which is the risk adjustment category for mood disorders. And finally, we're going to apply everything we learned to some real world scenarios. So you're not just learning theory, you're going to get to practice it. I hope that sounds good. Let's go to the next one. So why does this even matter? We're spending a whole webinar on mood disorders and mental health. And it's because the stakes are really high, really high money-wise. Incorrect mood disorder coding costs millions in missed risk adjustment revenue, for one example. So it's not that the doctors are actually performing the work, but they're not documenting it. So it's not getting coded correctly. So it's very important. And this is a confirmed fact. It's not just a maybe, or they're possibly losing money. They are millions in this field. So one of the most common mistakes we see is coding dysthymia as major depression. And when you do that, you're going to get claim denials really quickly. And then there's the HCC status impact. So if you code adjustment disorder when it should be major depressive disorder, then you're going to miss out on that HCC 59 qualification. And that's where the money is left on the table and those millions of dollars come in. So from a compliance standpoint, if your documentation doesn't support the code, now you have a different problem. You're opening yourself up to audits and potential recoupments where they want to get their money back. So it isn't just about getting the code right. It's about protecting your organization that you work for, maximizing your reimbursement ethically, and staying compliant. That's really why we're here. So let's start with the big one, major depressive disorder, or MDD. That's what most people think of when they hear depression. So what is it? It's distinct episodes of severe depressive symptoms that last at least 2 weeks and impact the patient's functioning. So the key word there, episodes. So major depressive disorder comes and goes in episodes. And we're going to need to track that because there's going to be one code for initial, another code for when it's recurrent. So when you're coding the MDD, those are the two pathways. You've got your single episode cares, and those are going to be the F32 series. And that's for the first documented episode of major depression. Then you have your recurrent codes, and that's the F33 series. And that's when the patient has had 2 or more episodes separated by a symptom-free period. So if they've had major depression 5 years ago, they got better, and now they're having another episode, then that's recurrent, F33. But the good news is that MDD qualifies for that HCC 59. So if it's documented correctly, it's going to impact the risk adjustment. So keep that in mind as we go along here. Okay, so once we know what MDD is, the next question is, how severe is it? So the doctor has, stated that it's major depressive disorder. Now we need to know how severe it is to get the most specific code. So, and this is where a lot of coders get tripped up because you've got to have the right severity documented to pick the right code. So we've got mild, which is F32.0 or F33.0. Why 2 codes? Because the first one is if it's single episode, the second one is if it's recurrent. And mild means minimal symptoms and functioning is only slightly impaired. Then we've got moderate, which is F32.1 or F33.1. And moderate symptoms are have a significant functional impact. The patient's struggling, but they're still getting by. Then we move into severe without psychosis. That's your F32.2 or your F33.2. That patient will have marked functional impairment, severe depressive symptoms. So this patient is really, really struggling. And then finally, we've got the severe with psychosis. That's your F32.3 for your initial or your F33.3 for recurrent. So this is severe impairment plus psychotic features like delusions or hallucinations. So here's the thing. The clinician must clearly document the severity level. If they just say depression, that's not enough. You need to see mild, moderate, or severe. And if it's not there, you got to query. So our CDI students, you know, query. You can't assume. So make sure your clinicians, if you're doing physician education, understand how important that is. Okay, so now let's talk about the dysthymia, which is also called PDD, persistent depressive disorder. So this one is different from the MDD. It's chronic low-grade depression that lasts for 2 years or more. Remember that, 2 years or more. So some people will describe it as depression as a way of life. It's not as severe as the MDD, but it's constant. It just doesn't go away. Now, when the code for dysthymia is, the code for dysthymia is F34.1. And this part's like non-negotiable. You never use F32 or F33 for dysthymia. Never. Those are the MDD codes. Don't mix them up. So dysthymia is F31.1. Now, when you're coding dysthymia, you also need to pay attention to the onset specifier. Is it early onset, meaning before age 21, or late onset, meaning age 21 or older? And then you need to know if there's a current episode or not, because dysthymia with a current episode qualifies for that HCC 59. But if they're stable or in remission, it doesn't. So you've got to have that documentation. So the critical thing to remember here is that dysthymia requires 2 or more years of continuous symptoms. It's not episodic like the MDD, it's chronic. So what does the documentation need to say to support dysthymia? Because incomplete documentation equals rejected claims or lower reimbursement, we don't want to do that. So let's go through this checklist. First, you need a statement about how chronic it is. The clinician needs to say, symptoms have been present for 2 years, or patient reports depressive symptoms since age 18, something like that. You need a time frame. Second, onset timing. Is it early or late? Early onset dysthymia, diagnosed at age 18, or late onset dysthymia, began at age 45. You've got to have some sort of reference like that. Third, the current episode status. Is the patient currently experiencing a depressive episode, or are they stable? Are they in remission? We need to know that. And finally, severity descriptor, mild, moderate, or severe, and describe the functional impact. How is this affecting their work, their relationships, their self-care? So the bottom line is clinicians must document specificity. Coders can't code what isn't documented. So if you're in a CDI role, this is where you come in and help them out. Query when you need to. Now we're going to move on to adjustment disorder with depressed mood. This one's really important because it gets confused with that MDD all the time, often. So what is it? Sounds a lot like what we've already said, and that's why we get the confusion. But it's a depressive response to an identifiable stressor. So the key word is identifiable. There's a clear trigger, job loss, divorce, a major medical diagnosis, relocation, something big like that. And the patient's symptoms don't meet the full criteria for a major depressive disorder. So the code for that is F43.21, but only when the depressed mood is the primary presenting feature. Now, timing matters here. The symptoms have to start within 3 months of the identifiable stressor. And then you've got to determine duration. Is it acute, meaning less than 6 months, or chronic, meaning longer than 6 months that has been going on? And the big kicker is, hang on here. Adjustment disorder doesn't qualify for the HCC 59. So if you code adjustment disorder when it should be major depressive disorder, you're going to be leaving money on the table. But if you code the major depressive disorder when it should be adjustment disorder, then you're overstating the severity and inappropriately accessing risk adjustment. And then you could be audited and have to give money back. So everything's about accuracy, the integrity of what really happened, that's being documented and coded and billed. So we want to get this right. And the key distinguisher here is that the stressor is documented for this adjustment disorder one. Okay, so how do we tell the difference between these, between the major depressive disorder and the adjustment disorder? Because they can look really similar on the surface, right? Let's look at some key features. So the first one we're going to look at is duration. Your MDD is 2 weeks or more per episode, and it can last months or even years. Adjustment disorder, acute is less than 6 months, chronic is 6 months or longer. The next feature is severity. Your MDD can be severe with significant functional impact. Adjustment disorder is usually mild to moderate with less functional impact. The next feature is the episode pattern. Your MDD comes in single or recurrent distinct episodes. Adjustment disorder is a response to an identified event. And then onset, MDD can be spontaneous. It can just come out of nowhere, whereas adjustment disorder happens within 3 months of a stressor. So when you're trying to make this clinical decision, ask yourself, not that coders are making a clinical decision, but you know what I'm saying. How long have the symptoms been present? How severe is the functional impairment? Those 2 questions are going to be important. And if you don't have that information, you need to query the physician so you can get the accurate information. And by the way, when you've queried the physician, hopefully they're documenting it, because you still can't document it from what they said. You need it documented. Okay. Let's go a little deeper on this stressor factor because it is critical. Adjustment disorder requires an identifiable stressor. Like we said, job loss, divorce, medical diagnosis, financial crisis, something. Whereas your MDD can occur without a clear external trigger. It might be spontaneous or even biological. And dysthymia, or the PDD, often has no stressor. It's just this chronic presentation throughout life. Now, here's the common error we see. When you're coding MDD, when adjustment disorder is actually the appropriate one, and when you do that, you're overstating that severity and inappropriately accessing the HCC risk adjustment, then you're at risk of an audit and having to pay it back. So the clinician has to ask themselves, is there an identifiable stressor? If yes, and it's recent and the symptoms are time limited, that's adjustment disorder. If there's no stressor and it's episodic and severe, it's MDD. If there's no stressor and it's chronic for 2 or more years, that's dysthymia. That's how you differentiate it. I hope it's all coming together for you. All right, now let's talk about a special category, depression due to medical conditions. This is an important distinction because sometimes depressive symptoms are secondary to an underlying medical illness. So when you use this category, when the patient has a documented medical condition like hypothyroidism, Parkinson's, diabetes, cardiac disease, and the depressive symptoms are clearly related to that medical condition, and often when you treat the underlying condition, the symptoms resolve or improve. That's a related condition. So how do we code these? So first, you code that underlying medical condition. That's your primary diagnosis. Then you're going to use the FO6.32 for mood disorder due to known physiological condition. And you've got to document clear causality in the clinical notes, not you, the doctor. Now, here's the catch. This one doesn't qualify for that HCC 59. So if you're thinking, oh, all depression gets HCC 59, that's not the case. And it's not like we're trying to document to get the HCC 59. We're just pointing out that getting it right, you know, if they do, you get the risk adjustment 59. But if they don't, and you code it, you're risking an audit and having to pay back money and, sanctions. So bottom line, always just code exactly what is documented. So I'll give you a little example here on the slide. A patient with newly diagnosed hypothyroidism presents with depression, fatigue, weight gain. You're going to put in code EO3.9 for the hypothyroidism. Then you're going to code the FO6.32 for the mood disorder due to the thyroid condition. So you wouldn't code that as a major depressive disorder, right? So hope that makes sense. All right, so now let's talk about HCC 59 in a little more detail. This is for your major recurrent or persistent depressive disorders. So who qualifies? For your major depressive disorder, that qualifies. Dysthymia with a current episode qualifies, but adjustment disorder does not qualify. And depression due to a medical condition does not qualify. So you've got to know the difference. Now, what's the reimbursement impact? HCC 59 directly affects the RAF scores. That's your risk adjustment factor. And each qualifying HCC increases reimbursement. So if you're missing HCC 59 documentation, you're potentially underfunding your organization. So we're talking thousands to hundreds of thousands of dollars, depending on your patient population. And from a compliance perspective, annual audits verify HCC documentation. If codes are missing or not supported, you've got compliance issue with potential clawbacks or recoupments, they like to call it. So this, again, isn't just about coding correctly. It's about protecting your organization financially from a compliance standpoint. So what does the documentation need to include for CDI and coding success? We're going to use this little checklist. So first, we need to consider the timeline. When did symptoms begin? And are they new or chronic? Any previous episodes? You got to have that documented. Second, the severity. Is it mild, moderate, or severe? What's the impact on daily functioning, work, relationships, self-care? Can the patient perform activities of daily living? Third, were there triggers or stressors? Are there identifiable life events or an absence of stressors? Is a medical illness contributing? Any recent psychosocial stressors? Fourth, what is the episode pattern? Is this the first episode or a recurrent one? How long between episodes? What's the current status? Acute, stable, in remission? And finally, what's their response to treatment? Is the patient on an antidepressant medication? Which ones? Are they engaged in therapy? Are their symptoms improving or stable? All of this needs to be documented. That's, again, the golden rule. It's got to be documented. And if it doesn't clearly describe the diagnosis, the code can't be justified. So educate your clinicians to understand what you need. So let's talk about the common errors we see, because we want you to avoid these like the plague. So error number 1, the wrong code for dysthymia. So if you're using F32.0 or F32.1, or and the F33.0 and the F33.1, these are the major depressive disorder codes. And the correct code for dysthymia is the F34.1. So if you use the wrong code, you're going to get claim denials and your HCC 59 validation failures. So that's that first one. And then the second one is misclassifying adjustment disorder. So using the MDD codes when there's a stressor-based depression, that code is F43.21 for adjustment disorder with depressed mood. If you mix this up, you're overstating severity and inappropriately qualifying for the HCC. Error number 3, missing severity and episode specifiers. You can't just code F32 without specifying if it's mild, moderate, or severe. You need F33.0, 0.1, 0.2, or 0.3. If you don't, then you have incomplete coding and your medical necessity might be challenged. And finally, error number 4, failing to update codes during the year. So let's say a patient was coded as an F3 2.0 for mild depression in January, but by June, they've escalated to an F3 2.2 for severe depression. If you never update the code, you're undercoding the severity and now potentially missing out on that HCC or RAF impact. So make sure you don't just copy and paste, the conditions forward. Like, be thoughtful about each thing that you're coding. Okay, so let's do a little practice. I'm going to give you a scenario, and I want you to think about what the correct diagnosis could be. So we've got a 54-year-old male who presents to his primary care provider 3 months after his wife's diagnosis of advanced cancer. He reports persistent low mood, difficulty concentrating at work, disrupted sleep with early morning awakening, and loss of interest in hobbies. He denies suicidal ideation. On assessment, he meets some criteria for depression, but not full major depressive disorder severity. He's experiencing significant distress, but he's maintaining basic functioning. He's still going to work, taking care of himself, engaging with family. So if we analyze this, is there an identifiable stressor? Yes, his wife's cancer diagnosis. What's the timeline? Do we have a timeline? Yes, the symptoms began within 3 months of the stressor. Does he meet the full MDD criteria? No, he's got some symptoms, but they're not severe or impairing enough. What about the functional impairment? Mild to moderate, not severe. So what's the correct diagnosis code? What do you think? Boop. So it's F43.21, adjustment disorder with depressed mood, acute. So sorry, I didn't give you guys enough time. I'm feeling a little stressed for time. So why not major depression? Because the symptoms lacked severity, duration. So remember, your MDD needs at least 2 weeks minimum and functional impairment of your MDD. And there's a clear temporal relationship to the stressor, which supports adjustment disorder diagnosis. Now, what's the impact, the HCC impact? F43.21 does not qualify for the HCC 59. So if you inappropriately code this as F32.1 for moderate depression, you're overstating the severity and incorrectly accessing risk adjustment. That's a compliant no-no. So you've got to get this right. All right, 2 more slides. We're in the home stretch. We're wrapping up. But I want to leave you with some kind of little to-do list. We're teachers, got to give you homework. So first, go review your organization's mood disorder documentation templates. Make sure they're capturing all the elements that we talked about today. Second, audit your recent mood order coding for accuracy against these guidelines and see if there's any patterns or errors that you need to address. You'll be a hero in your office, because if your office is guilty of some of those things where they're leaving all of this money on the table that they rightfully deserve, you'll be a hero. Third, train your clinical staff on HCC 59 qualifying criteria. Make sure they understand what needs to be documented and why. And finally, establish a CDI querying protocol for those borderline cases, your MDD versus adjustment disorder, dysthymia versus your MDD. You need a kind of a process in place for getting that information out of them. So those are your action items. And I just want to say that you guys did great. We're at, we normally do, these are about 90 minutes. Sometimes they're a little shorter, but this was a very, very meaty one. So we're glad you stuck with us. But if you have questions, come to the Academy. Even if you're a free member, we have that free area. You can ask questions. We're always there to help. But if you're like a club member and you work in this specialty and you have a report and you're not sure, you could send it to us redacted and say, my provider thinks it's this code, or I think it's that code. We don't want to do your coding for you, but we are willing to confirm and teach why you're right or wrong. So that's the only request that we ask, is give us what you think the code is so that we can help you understand why. We're big on rationales. So that's a wrap. Thank you for your kind attention. We had a pretty good sized group. Any questions, or are we good?
You know what? There is no questions. They must have been completely enthralled. A lot of thank yous. And the forensic coder is that everybody's still very interested in this. Thanks, Camilla. She said, thank you for a wonderful
CSI.
Probably. You're right.
I remember when I was first teaching, I would we'd go to that section of the coding manual for pathology, and it was, the forensic coding. I said, now we're going to talk about the Quincy codes.
Yeah.
And I'm sure many people in the audience are like, Quincy? That was an old show.
I remember Quincy, and I loved that show as a child.
And he was a forensic, physician, and there'd be a murder, and he would have to figure it out, from a doctor's perspective. And then, of course, we had the whole CSI New York, crime scene. Yeah. So at any rate, thanks for your kind attention.
Yeah. And we had some real good comments. Thank you, guys. If you like this, type of presentation that focuses both of our topics as a theme, let us know. And that, again, we can continue to do that, but it's all based on the questions that you give us. So thanks, Margaret, for your kind words. And then, Cynthia said she loved Quincy as well. We're dating ourselves, aren't we? I remember I was young, but that was one of the reasons I really wanted to get into medicine. He was a forensic coroner, and so it was a great show. Yeah, forensic coroner. In fact, I tell people now I would like to be the county coroner. It sure doesn't pay anything, but as you get into retirement, you're just like, yeah, I'd like to do that. Nobody can figure out why you'd want to ever do that. So
yeah. But and I do want to remind everyone, we do have a corporate side of what we do. We do audits, and we do training for practices. We do what's the word I'm looking for? Contract coding. So if you already work in a practice and you feel like they could use some extra education that's customized, reach out to us. We're happy to do that. And we've received really positive feedback. A lot of it's because we're very we're not stiff and formal. We're very casual and I think a little more fun. And that resonates with people and helps them to really pay attention and get the information instead of someone kind of being more robotic. So anyway,
Catherine wants to know when the CCO conference is going to be. We've talked about that for years. Maybe it'll happen. Now that CEUs are so expensive, I tell you, that's a real burden for educators, but
we need more people in the club so that we can buy more CEUs for you. That's what we need. So
pass the word, guys.
Refer your friends. We really appreciate it. So all right. Thanks, everyone. That's a wrap. And hopefully we'll see you. I won't be here next Thursday. Alicia's going to cover. I'm on vacation. I'm going to Daytona Bike Week and the Florida Keys with my sister on our Harleys. So pray for us that we're safe. And I'll see you a week after next Thursday. So
all right, guys. Thank
Bye,
you.
everyone.
Looking for medical coding, medical billing, and risk adjustment education? Learn more at cco.us.